Good evening. I'm a pain physician, and I have an interest in neuropathic pain. This is nerve pain. Now we see this with spinal cord injury, because pain following spinal cord injury is common, and but I don't see very many spinal cord injuries as such. Tonight I was going to talk about another condition which has neuropathic pain as one of its main presenting feature, and it's very similar to some of the features that you have with spinal cord injury. And also I'm going to diverge in the middle and tell you about a very ancient history of treating this going back to Neolithic times, which hopefully will be interesting to you. Spinal cord pain following spinal cord injury is common. Up to about 60% of spinal cord injury patients have a pain state, and it can be from a number of reasons. It can be due to mechanical spinal injury from mechanical components, fracture, and subsequent surgery. You can also have a central pain state due to altered brain and spinal cord circuitry, and a neuropathic pain state, which is due to damaged nerves. And this is the subject that I'll talk about tonight. There are also other causes of pain following spinal cord injury, including upper limb from shoulder and elbow from use of wheelchairs, and muscle spasm and visceral pain. So the condition that I was going to talk about is complex regional pain. It follows injuries. It can start after a minor injury. The pain spreads. It's often described as being burning, and until recently it was thought to be a psychiatric problem. It's very hard to deal with for patients, and it's a pathophysiological puzzle. And I've been interested in this for about 25 years, studying it with Professor Drummond at Murdoch University. And we've published a number of studies into this condition. So I don't know if you can see this. This is a patient's foot when they develop complex regional pain. They have often have burning pain. They have sensory disturbance. They can't feel normally. There's weakness, cramps, and a tremor quite often. There's swelling, sweating, and vascular disturbances. So some of these features are probably quite familiar to you with spinal cord injuries. Next, here's a much worse version. They vary in extent from very minor to severe distortions such as this. Thank you. It's quite a rare condition overall, but they tend to get concentrated into pain clinics, and that's why I see them. It's more common in adulthood and in females. In fact, at pain clinics, females predominate on males by about 60 to 40. There's often altered sweating, and which is hyperhidrosis, and other autonomic features. Various factors make this pain worse: moving, touching, loud noise, emotional excitement. Next, thanks. There are various concepts as to neurophysiology of this condition. I won't go into this in great depth. I was unsure of the audience tonight, so I'll perhaps skip over this. But one of the features is inflammatory response, and this is called neurogenic inflammation. There's also altered sympathetic function, and that's our particular interest at Murdoch University, and also changes up in the central nervous system. So the next picture just shows the features of this. I don't know if I can show you with inflammation in the periphery. Say there's been a minor injury there, then altered connections in the nerves going up into the, and then altered changes in the brain. So there's a number of features of this condition, but it's only partly understood. Next one, thanks. And this is our current interest. We're looking at changes in what's called alpha-adrenal receptors, which become upregulated and affect sensory nerves going into the central nervous system. So you get an altered and upregulated adrenal receptors. Thank you, Nick. And we've been working on this. We've demonstrated expression of these alpha-adrenal receptors in the skin of and dorsal root ganglia of rats. And next one, and recently we've just published a study showing that you have upregulation of these receptors in rats, in the skin rats after certain sort of injuries, and also in humans that have got this complex regional pain state after nerve injury. Next. How do you treat this neuropathic pain? Well, there are various techniques, pharmacological, non-pharmacological, and various interventions such as spinal cord stimulators and sympathetic blocks. Next one.
Sorry.
Yeah, sorry.
The one you said is like stimulate the nerve.
Yeah.
Is that found to be effective though?
Mixed, not wonderfully. You mean peripheral nerve stimulation? No, the evidence not. Or sometimes you get reasonable results. But next one. Physiotherapy, non-interventional techniques to start off with. Physiotherapy, there's mixed evidence. It does help to some extent, and I think we all feel that functional restoration is important. I'm sure that's a very important part of spinal cord injury rehabilitation as well. Next one, thanks. There's a technique called mirror therapy for this condition where you have a mirror in between your lower limbs, if it's a lower limb problem, and when you're moving your good limb, you think you're moving your bad one, and vice versa. And it's hard to explain this to you, but it is a reasonable technique for this condition. Next one. Various drugs are used in the treatment of complex regional pain and neuropathic pain in general. There's many medications advocated, but few of them have been really proved with randomized controlled trials. A rational mixture of drugs is the best in this form of treatment. Next. Just briefly, the drugs, Dr. Cherry mentioned some of them. We use anticonvulsant drugs such as Lyrica and gabapentin, which you're probably familiar with, antidepressant groups in various types. This is an older one, amitriptyline, opioid drugs like morphine, and some topical agents. And I'm going to diverge in a minute into topical agents because it's a particular interest of mine, and it goes back many thousands of years. And so we'll get on. Now, there's a thing called the number needed to treat in neuropathic pain. That's the number of patients you have to treat to get a successful result, and it's really quite high. So the drug that's really advocated for treating neuropathic pain is this one, gabapentin or Lyrica or gabapentin, and you need to treat 4 people to get a good result. So the best drug that we have for treating this condition you need is not all that successful. There are other ones here. You can see antidepressants, opioid drugs such as morphine, tricyclic antidepressants, Botox is of some use too, and tramadol, which Dr. Cherry mentioned, which is an opioid drug. Next one, thanks. Ketamine is of particular interest to me. It's quite helpful in some neuropathic pain states. It's been tried in different ways, intramuscularly, under the skin, epidurally, orally and topically. The trial, there's been a number of different trials, and we've been involved in one. I've published a paper on topical application for complex regional pain a few years ago. Next one, please. Ketamine has a mixed press. Some people call it a K-hole. It can be anything from going to hell and meeting Satan to going to heaven and meeting God. The frequent use of ketamine can affect your memory, and it can affect your urinary tract as well. Next one. I've used it in spinal cord injury patients, given under the tongue or orally, and also topically. Next one, thanks. So topical drugs are quite useful in neuropathic pain states, such as complex regional pain and shingles, for example. And they act in a local fashion on the skin, and they don't affect your brain greatly. So next one. So, and you could possibly see this is shingles, eruption of shingles, which is a very painful condition, and it's a typical neuropathic pain condition, and it requires very much similar agents that we've already discussed that are used in complex regional pain and also in neuropathic pain in spinal cord injury patients as well. We studied this in a paper that was published. Allodynia is if you touch something normally that doesn't hurt, but in someone with this condition, touching them it can be exquisitely painful. It's called allodynia, and we found that this could be reduced by applying topical ketamine. So it's an interesting drug. So this is where I divulge. I hope you don't mind, because I thought I didn't want to bore you too much with all this scientific stuff. This is, I looked in, I've got an old book at home called Carl Pepper's Herbals, and I looked in that for sciatica, and it said there, the leaves, but especially the root, taken fresh in summer time, beaten and made into a poultice or salve with old hog's grease, and applied to the places pained with the sciatica, to continue thereon for 4 hours if it be a man and 2 hours a woman. I'm not sure why, sorry, because we seem to be, yeah. The place afterwards bathed with wine and oil mixed together and then wrapped with woolen skins after they have sweat a little will assuredly cure not only the same disease in hips, hucklebone or other joints, etc. Yes, so I started looking into neurotopical agents, and in fact topical things have been put on the skin since antiquity. Next one. They go back to Neolithic times. Our ancestors were slapping things on, and in Mesopotamia there's evidence that various agents were made up from seed, barks, wine and other ingredients. Next. In ancient Egypt there are records of topical agents being used. For example, if you look at this, I guess that that looks like a bee, so that's a honey. This is a hieroglyph. They bind with oil and honey to improve wound healing. In fact, it dries out a wound, this mixture, so that's possibly how it works. Honey is also antibacterial. You've probably heard of this. If you've got nothing else to treat a wound with, honey is not too bad. Then I looked in the Bible, and there in the Old Testament it said, for Isaiah had said, let them make a lump of figs and lay it for a plaster or plaister, that's how they spelt it, upon the boil, and he shall recover. And also in the New Testament, when he had thus spoken, you know who he is, he spat on the ground and made clay of the spittle, and he anointed the eyes of the blind man with the clay. So I visited Israel years ago, and this is my daughter here, looking with amazement at these people that have slapped the mud from the Dead Sea on them, because they find that this helps in rheumatic diseases, and it's actually used in some of the hospitals. Next one, thanks. Topical means, topos comes from the Greek, means local place or location. And in the Greek literature, there's topical agents made from saffron, which is that really that intense yellow that comes from flowers, saffron, and salts and oxides of copper, which are the bluey green. Next. Mandrake is particularly interesting in the Middle Ages. The juice from the finely grated root was applied externally to relieve rheumatic pains, ulcers and scrofulous tumours. Scrofulous tumours are TB tumours. Next one. The mandrake root is actually a hallucinogenic agent, and if you look in the literature, they say a furrow must be dug around the roots until its lower parts are exposed. Then a dog is tied to this, after which the person tying the dog must get away. The dog then endeavours to follow him and so easily pulls out the root but dies suddenly instead of the master. After this, the root can be handled without fear, because handling a mandrake root was thought to be quite dangerous. Next one, please. And there's the dog in an illustration from the Middle Ages, and here's the mandrake root. Next one, please. And going a bit further, in the 13th century, this is podagra's gout, applying topical agents to gout. Now, there's an interesting story. Huao Tu was a physician in ancient China. He was born in 110 AD and murdered in 207 AD. He was a famous physician. He was an accomplished Taoist. He did not seek fame and fortune, which is most unusual for doctors. Known as a divine physician because he preferred simple methods, using a small number of acupoints and formula, etc. And the next story concerns a famous general, Guan Yu, who was a general in the kingdom of Shu. And he got shot with an arrow in a battle of Fan City. And the physician that I showed you before, he made an incision in the arm and scraped out the dead muscle. And Guan Yu continued to drink and play chess and laughed and talked as if nothing was happening. And the reason was because mandrake juice had been applied to his wound and was a local anaesthetic agent. So, and then I go up to China quite often, and topical treatment's quite contemporary there. You see moxibustion, heat applied to the low back. These are suction bells. And next one, you see contemporary poultices in China. Next one, you see, and then if you have a look at Indian ancient medicine, Ayurvedic medicine, they use topical agents. Next one, and crown flower, the leaf is heated over a fire and applied to affected area to relieve pain. So then going to next one, to India, again in India, the patient lies on a plank of wood from a jackfruit tree and is rubbed with warm medicated salts and herbs. A lot of topical agents throughout history. South America, coca leaves, cocaine comes from. Traces are found going back 3,000 years to the Moche period, and this has topical local anaesthetic effects. Next one. In Australia, of course, indigenous people in Australia have pharmacopoeias, extensive pharmacopoeias, going back 60,000 years, one presumes. Each areas have different pharmacopoeias too. Next one. North American Indians have similar pharmacopoeias, and again, for example, and a modern example of this is stinging nettle cream, has some evidence base to it. Next one. And going last of these topical, if you go to Martinovich, who's a chiropractor, I don't know if he's still in practice in Fremantle, he will apply a linseed poultice to your low back. And he kindly let me go and watch him one day. Next. So CRPS is treated with a number of interventions as well. These are local anaesthetic blocks, but the pain often returns, and trying to cut the nerve doesn't work, basically. Next one. This is someone with CRPS. You can see it's a blue colour. They've got burning pain, and they were treated with a sympathetic block. That's to warm up the leg with an injection of local anaesthetic on the sympathetic chain. And next one, and if you can see, it's changed colour, and it did actually cut down the pain significantly. And then later on, this person was treated with Botox, a sympathetic block, which worked very nicely. Next one. The evidence in base for sympathetic block is somewhat limited. There's only been a few randomised controlled trials that meet a reasonable level of evidence. Next one. So the conclusions, which are really for complex regional pain, neuropathic pain, which is part of, and spinal cord injury pain, are very similar. No particular class of drug or method of administration is particularly effective. Anticonvulsants, that's Lyrica, pregabalin, gabapentin, and tricyclic antidepressants, probably the first line of treatment. Topical agents, which I just told you about with this ancient history, may be helpful because their stuff doesn't go up to your brain. Physical therapies are helpful. That's physiotherapy, functional maintenance, occupational therapy is helpful. Interventions such as sympathetic blockade and spinal cord peripheral nerve stimulation is limited in its effect, and a multidisciplinary approach gets the best results. For example, there's a multidisciplinary clinic here in this hospital that I'm sure some of you have been to, but not always possible because a lot of these patients are treated in private practice or outside. So just last, we're after some. We have, as Louise said, we're studying neuropathic pain down at Murdoch. We just love to meet people with neuropathic pain, and we're wondering if any of you have one-sided pain following a spinal cord injury, whether we can study you. We'll come to you because we're looking for, you may have a level, say, in the mid-thoracic region, but we found with complex regional pain that there are changes up in the forehead, in the hearing, and we want to study these if possible. So if you're feeling generous with your time and you'd like to be, we'll give you a certificate afterwards for being a lab rat. We'd like to meet you if you could talk to us. Thanks. Thank you, Louise. Thank you.
Am I right in understanding you correctly in that inflammatory cytokines can actually transfer themselves up through the peripheral nerves into the spine?
No, they're sort of they're involved in the sort of inflammatory response in the periphery because the condition that I've talked about is usually a peripheral thing. It was first described in the American Civil War when people had been shot with a low velocity bullet, but and the changes start in the periphery, then they spread, and then they affect your brain eventually. So the cytokines is a peripheral thing.
Are you saying that they affect the brain by altering the nerve centrally?
Correct. Yes. Yeah.
So they don't actually.
So we think that one of the mechanisms is this change in alpha-1 adrenoreceptors, because we've been studying alpha-1s with immunohistochemical techniques in rats and in humans.
And that's how you find the upregulation taking
Yes,
place?
that's and we've just had about 3 publications in the last few months actually looking at this. There are various models of this condition in animals. You can, I hope none of you are sensitive to investigating animals, but you can cause a nerve injury in the nerves that come out of the spine. You can partially injure it, and the rats develop a condition which is a bit like the human one. You can make a tibial fracture, and as it heals, they develop this condition. You can compress the nerves, the sciatic nerve, and it's called a chronic constriction injury. And again, this condition will come on in rats. So there are a number of models, but it's very hard to ask a rat how bad the pain is. You can watch how they react to it. They don't like to put their foot on their leg on the ground, and so it's a behavioural thing.
So knowing you've got this upregulation of the
Yeah.
alpha-1 adrenoreceptor, you've now got no technique to actually downregulate it then.
Well, that's what we'd like to do if we can, but we don't know why. Actually, one of the highest upregulation areas is in the keratinocytes, in a layer of the skin, the outer layer of the skin, and we found in CRPS that there's an upregulation in the non-involved limb, i.e. on the other side of the body. So we're wondering whether there's an upregulation in other tissues in the body, like the kidney. So it's an interesting. In fact, we're now looking at burn patients with. We're looking at burn injuries. We haven't published this yet, but there's a big upregulation in alpha adrenoreceptors following burns. So,
Doctor, you mentioned looking out for volunteers for pain research. You mentioned only one side of pain.
yes.
Is it left side, right side, or up or down?
Yes.
It doesn't matter. When you say one side of pain.
Yeah, hemilateral, if possible. I know with spinal cord injury it's often bilateral, but
So you're ruling out any volunteers potentially who are currently.
no, we'd like to study anyone if they don't mind. Another group would be those with amputations. Is there no one with an amputation here? But amputations are obviously they're unilateral, and we think that they'll probably have central changes as well.
Can I just ask what
Yeah.
There's been some work into magnetic brain stimulation a little bit.
Not for CRPS. No, I don't think it's been. Maybe it's been tried, but it's not an effective.
Okay. Or deep brain stimulation?
Occasionally, we send patients up for DBS, but they invariably get knocked back. So we haven't had much success there. There's a neurosurgeon at Charles Gardner that does DBS.
Yes.
You know him.
Yes.
Yeah. Chris.
I've got a right break question.
Yes.
And I suffered some
We'd love to meet you. Do you feel like being a lab rat?
I've got time.
Yes. Well, we'll come to you because we just want to look at sensory changes. And we won't hurt you.
Well, thank you very much.
Yeah, cheers, yeah.